We're very fortunate to have Dr. Eva Ihle, who is professor of psychiatry here at UCSF, and she's actually got joint appointments in our UCSF departments of psychiatry and also in pediatrics. She is a neuroscientist who has a strong research background, as well as a board certified child and adolescent psychiatrist. She's held a couple of different leadership roles within UCSF psychiatry, within the main UCSF child and adolescent psychiatry outpatient clinics, as well as the Zuckerberg San Francisco General Hospital Child and Adolescent Psychiatry Program. And she currently provides a pediatric psychiatric consultation liaison service at BCH Oakland, and on the adult side, consultation liaison at the UCSF Parnassus campus. Dr. Ihle will be speaking with us today on adverse childhood experiences, toxic stress, trauma, and insights into interventions for youth. Dr. Ihle?
All right. Well, thank you very much for the invitation to participate in Project ECHO. This is actually my second presentation for Project ECHO, and I really appreciate what this project is able to do for those of us working with kids. So thank you for allowing me to be here. I am going to drive my slides. So here we go. Before I begin my presentation, I do just want to acknowledge that UCSF is situated on land that was taken from the Yelamu Ramutesh Ohlone peoples. I don't have any conflicts of interest to report or to disclose, but I will note some additional disclosures here. The first few relate to CAP, and the second points relate to my presentation, specifically that the medications that I'll be discussing toward the end are off-label in terms of their use in the setting of traumatic stress. Because few of the medications that we actually use are approved for use in children. All right, so the impact of adversity as it relates to both emotional and physical well-being are going to be addressed in this brief presentation. And so my objectives for this primer on toxic stress are listed here. I'm going to focus mostly on the first two in terms of understanding the relationship between adverse childhood experiences and toxic stress, and then the impact of toxic stress on emotional and behavioral regulation. Those are the key points that I hope that my presentation will address. And in the mix is this third objective, which is to identify for our patients what some culturally sensitive interventions might be to help mitigate the effects of toxic stress. So to make sure that we're starting from the same foundation, I'll start by defining toxic stress. And I chose to use this quotation from Nadine Burke-Harris, who was our first California Surgeon General. And one of the earliest proponents of addressing toxic stress. This quotation is taken from her book, The Deepest Well. And the definition that she gives for toxic stress is that it's a constellation of symptoms in line with what we know happens when there is prolonged activation of the stress response system without adequate support. So again, prolonged activation without support. So in order to understand the relationship between adversity and toxic stress, I first want to delve deeper into the relationship between adversity and traumatic stress. So We'll go into more detail about ACEs and consequences in the next few slides. But first, I just wanted to address some generalities. We have more and more evidence these days that adversity has an impact on overall well-being. We are understanding that exposure to ACEs, adverse childhood experiences, causes a stress response or a stress reaction, and that the prolonged stress reaction can have maladaptive consequences. And these are both psychological sequelae as well as physiologic sequelae. Just to review, when we're talking about adverse childhood experiences, we are referring to this long list of experiences. And the accumulation of these experiences throughout development are what can cause traumatic stress. So we know that neglect in all of its forms is a huge trauma, and then, not surprisingly, all forms of abuse are also traumatic. And then things that people don't tend to think about, well, maybe this audience thinks about it, but a larger audience doesn't necessarily recognize that even witnessing violence, being exposed to community violence, in addition to domestic violence, can be an ACE. And then being separated from caregivers is also considered an adverse childhood experience, as well as being exposed to caregivers who are dealing with active substance use or with untreated psychiatric disorders. Of course, it's also important to remember that threats to bodily integrity, whether, again, it's in the form of community violence or whether it's in the form of chronic medical illness, is or can result in traumatic stress. So all of these things together, or in some combination, can result in traumatic stress. So I mentioned that there are psychological sequelae to prolonged stress. And again, we're talking about maladaptive consequences here. I'll get into adaptive consequences momentarily, but the maladaptive consequences psychologically include some of the changes that are listed here. So changes in emotions such as fear or anger or even suicidality. There are cognitive changes as well. So difficulty attending to and integrating information, having poor focus, and then things that we tend to associate with PTSD, such as a sense of foreshortened future. Of course, there are behavioral changes as well. Things like addictive behaviors in older kids, avoidance, aggression, and dysregulation in all ages. And of course, these changes can cause distress and dysfunction in academic and social realms. And of course, the problem is that these changes limit developmentally appropriate adaptive behavior. There are additional physiological consequences as well. There is mounting evidence that adversity has an impact on physical well-being. Lots of different systems are affected. The top one that I've listed here is respiratory. Interestingly, there's a lot of data suggesting that ACEs increase the risk of asthma onset. So there's an association between adversity and asthma of a physiologic nature, not what we used to think, that it was limited to socioeconomic stressors, but there are physiologic responses as well. That's true also for the cardiovascular system, the endocrine system, and the immune system. These are the top of the heap in terms of systems that are affected physiologically. And this change, the physiologic sequelae, is what the term toxic stress is referring to. What we often see clinically is what is coming to be termed the toxic stress triad. It's an unofficial term, but it refers to the idea that there are three phenomena that tend to hang together when a child is exposed or is experiencing toxic stress. These are asthma, atopy, and obesity. And the link is likely related to stress physiology. There's immune dysregulation in the setting of chronic stress, and there is increased inflammatory responses. And so toxic stress tends to undermine immune regulation, likely through the effect of glucocorticoids, resulting in these clinical syndromes. I alluded to the idea that there are positive effects of stress, and I want to highlight this because stress isn't always bad. And in addressing toxic stress, we can formulate our interventions from this perspective, that there actually are positive effects of stress. We know that the stress reaction has an adaptive role. This fight or flight response actually supports survival. We have it for a reason. It keeps us alive when it is working on the short term. As the quotation I shared earlier highlights, it's when there's an overactive stress response that is prolonged and that doesn't have adequate support that we get into trouble. But the stress response in and of itself is adaptive, and it can help rather than harm. I also want to highlight that there's actually what I call an auspicious role of stress. It can actually compel us to learn new things. For some individuals, it can bring about new peak performance, and it can also foster post-traumatic growth, where individuals can gain strength and wisdom from challenges. I will highlight that what I'm describing here in terms of learning and performing are in the context of stressors that are anticipated and relatively minor. So when we're talking about ACEs, it's not exactly the auspicious type of stress that that peak performance usually is associated with, but there is a link here and something that can help guide us when we're taking care of kids. I also want to talk about the topic of salutogenesis, which is related to post-traumatic growth. Both of these concepts are associated with the positive psychology movement, where salutogenesis, again, if you break down the term into its component parts, it's basically referring to the process of achieving wellness despite trials and tribulations. Post-traumatic growth, again, is where individuals can gain strength and wisdom from coping successfully with personal crises. There's a lot of debate in the positive psychology movement about the definitions. Ultimately, what it boils down to is that negative stressors can produce positive change under the right circumstances. And so I want to highlight that because I think that can help motivate us. So in terms of supporting salutogenesis, again, in our goal to achieve well-being, we can think about it theoretically and establish a philosophical underpinning for the work that we do, that understanding that psychological well-being is a large component of overall wellness. And I'm going to offer another quotation again, this time from David Satcher, who was our Surgeon General, our United States Surgeon General in the late 90s. And he said that there is no health without mental health. And I am a firm believer in this perspective. And so it's important when we're trying to support salutogenesis that we pay attention to the internal world of the child, its outward manifestations, and of course, its cultural context. And by paying close attention, we can recognize and manage psychological stress and distress that is caused by exposure to adversity. So beyond the theoretical, we can talk about some practical efforts to support salutogenesis. Those include offering trauma-informed and culturally grounded care, harnessing resilience factors, especially those modifiable resilience factors that we know exist in our patients. And those are the resilience factors that we can use to promote fortitude and growth. And this supports overall well-being, again, even in the setting of adverse circumstances. Again, we can help to manage psychological distress through trauma-focused therapies, and then linking individuals to interventions that can help improve functionality and behavior regulation. So I'll shift now to the idea of interventions, just to talk a little bit about that. And again, the organizing principle here is that the nature and the degree of the distress or the dysfunction will influence the approach that we take in terms of our interventions. So when we're talking about interventions to modulate the stress response, we can organize them into non-pharmacologic interventions and then pharmacologic interventions. I'm going to start with the non-pharmacologic, in part because they are more widely available, and oftentimes they are more readily accepted as interventions. So I have borrowed this image from the CalHope website. Again, this is something that our first California Surgeon General, there's a second one now, but our first California Surgeon General put together some information about stress and what to do about it. And it can be found on the CalHope website. So there are at least 6 different non-pharmacologic interventions. And they are all reasonably straightforward. It's important to eat well, be physically active, get good sleep, and then also focus on the internal world through mindfulness practices, having access to mental health care, and of course, accessing supportive relationships. For the quality sleep, so I'm just going to highlight a few details about some of those interventions. The quality sleep idea, it's important to encourage good sleep hygiene through things like bedtime routines. For physical activities, it includes things like relaxation exercises. You could also consider that in the mindfulness category, but things like yoga, in addition to mindfulness, can be helpful. I included nutrition under physical activity. I'm not sure why there was a rationale behind it before, but I can't quite remember since it is separated into a category in of itself. But things like participating in sports, whether it's club sports or just casual activities, whether it's team sports or individual, just getting out there and moving. And then, of course, for mental health care, and again, I'm including other areas under this category, but the idea that we can strengthen pre-existing relationship supports. So we're helping our patients by helping the systems in which our patients find themselves. That's an important principle that we've been familiar with for some time, but that we can encourage in terms of our treatment plans for addressing toxic stress. Spiritual practices and traditional ceremonies can be really important in addressing toxic stress. And of course, the more traditional and established trauma-focused therapies that are behavior-based are also included in the mental health care intervention. So then, in addition to these non-pharmacologic approaches, we do have some medications that can be helpful in targeting the stress response directly. And again, I'm focusing on stress physiology. I'm not talking about anxiety, but rather the physiology underlying the fight or flight response. So these agents are the adrenergic agents. I tend to emphasize the alpha adrenergic agents, but beta adrenergic agents can be helpful as well. The alpha adrenergics, because they're centrally acting, have a more profound effect on the stress response. It's not just the physiologic impact, but it also targets some of the psychological components as well. The two agents that tend to be available for prescriptions are clonidine and guanfacine. Clonidine is a little dirtier in that it's active at 3 different alpha-2 adrenergic receptors. It also has a shorter half-life, so it requires more frequent dosing and carries a little more risk of rebound hypertension. Common side effects include sedation and hypotension. Guanfacine is basically the better version of clonidine. It's more selective, so it acts only at the alpha A receptor as opposed to clonidine. It has a better side effect profile, in part because it has a longer half-life, better than clonidine is what I mean. And then in terms of side effects, they're similar to those of clonidine, but for guanfacine, there's also the likelihood of dry mouth as well as constipation. And all of these side effects can be mitigated to some extent by ensuring hydration. So just having kids drink a little more water, which is also healthy. So I'll wrap things up in the interest of time, and list a few of my conclusions as my take-home points. These are that interventions that address toxic stress can ultimately promote well-being, both in children and their family members. And interventions are fairly broad. They include both non-pharmacologic and pharmacologic options. And when the non-pharmacologic interventions are culturally sensitive and salient, they are especially effective. And ultimately, all of these interventions have the goal of enabling children to grow up with a sense of wellness and community. These are the sources of information that I used to inform this presentation. And with that, I will thank you for your attention.